I'd like to welcome everybody to our next episode of AI in Medicine. Today, we're going to be talking about the company Volta. It is an AI-guided ablation of atrial fibrillation. Again, my name is Louis Shendowich. I'm a hematology and oncology fellow at MedStar Georgetown University Hospital. I have no conflicts of interest or disclosures to report for this. So the journey for this specific company starts in 2017 when they developed a physiologic concept of really looking at electrograms to try and identify drivers of atrial fibrillation. From that 2017 paper, they went to a 2022 AI model development paper. And this is really what we're going to be talking about today. And this specific paper really focused on developing a model that can accurately and automatically detect dispersion signals in real time. This is followed up by the tailored AF trial, which is a prospective randomized controlled trial that really tests the AI model to see if it's clinically validated. There are two other papers that we're not going to review. One is the mechanistic characterization, and the second is the restart trial. So in regards to background, atrial fibrillation is an atrial arrhythmia characterized by uncoordinated atrial activation and irregular ventricular responses. Atrial fibrillation is the most common sustained cardiac arrhythmia. In the United States, prevalence is projected to reach 12.1 million by 2030. Catheter ablation is a minimally invasive procedure that uses energy to create scar tissue in the heart, electrically isolating the pulmonary veins from the left atrium to prevent atrial fibrillation triggers. Pulmonary vein isolation is the standard approach, and there's different methodology you can use, such as radiofrequency ablation, cryoballoon, and pulsed field ablation. With a single procedure success rate that ranges from 50 to 60%, and which does tend to improve to 79 with multiple procedures. On the right here, you can see what a normal rhythm looks like, and also compare that to an atrial fibrillation rhythm. So for cardiac ablation, what are we really talking about? There's two main steps. The first one is analysis. The second one is intervention. So the first part is in analyzing the left atrial mapping with intracardiac electrograms. The second is the intervention. And this is when the physician creates a ring of ablation specifically around each pulmonary vein antrum. On the right here, you can see what an example electrogram might look like if it were to be mapped out. One of the key concepts that this AI model utilizes is something called spatiotemporal electrogram dispersion. This is abbreviated as STED, and I will be referring to this as dispersion throughout the presentation. It really refers to asynchronous activation across multiple electrodes over time. And what this suggests is that there's a nearby atrial fibrillation driver. You can see here on the right an example of dispersion versus no dispersion. So the clinical question now becomes, can we identify dispersion patterns within the mapping, and can we ablate those lesions to improve outcomes? That's the whole point of this specific AI model. So in order to do that, let's start with the 2017 model that really addresses the clinical question, is STED ablation better than standard PVI? And this was really a prospective non-randomized interventional study that involved 105 patients undergoing atrial fibrillation ablation versus a historical control of 47 patients. The intervention was a physician-guided ablation, specifically of the STED or the dispersion pattern that we mentioned before, and there was no planned PVI in this intervention. The primary procedural endpoint was termination of atrial fibrillation, which occurred in 95% of patients with dispersion-guided ablation versus the 60%, which is the historical control. There was around 77% of patients who converted to sinus rhythm with the ablation itself. Now, some of the most important things is the long-term recurrence of atrial fibrillation. And recurrence of atrial fibrillation or atrial tachycardia 18 months after one procedure was 11% versus 58%. And one of the key and most important limitations of this paper is that it was entirely physician guided. It was operator dependent, and there was a high possibility of really operator error. And that leads us to the 2022 AI model development paper. And really the goal of this paper was to develop an AI model that can standardize identification of STED regions across operators and centers. How did it do that? Well, it used a training population of a largely proprietary database of expert annotated atrial fibrillation electrograms. And it also used a validation population of around 85 patients across 8 centers and 17 electrophysiologists. The intervention that was attached to this AI model development was AI-guided ablation, with PVI being optional and performed in around 42% of the patients. The primary endpoint was atrial fibrillation termination during the procedure, and the secondary was really conversion to sinus rhythm. On the right here, you can see an example of where a dispersion area might be and the dispersion area that may be ablated afterwards. So before we talk about the results, I do want to give an overview of the AI model that was used and go through the specific steps in the development of it and how it actually works. So the first step is that the electrogram signals are recorded during atrial fibrillation. That data is then inputted into the specific model. This is a multi-electrode catheter recordings that is going to be used as the input. Step 2 is signal processing and feature extraction. This basically does result in raw signals converted into structured inputs for analysis. Step 3 involves where the AI models do a lot of the work, and that's specifically the 2 models trained on expert-labeled examples of dispersion versus normal signals. The first is a feature-based model. It uses XGBoost, and it's learned statistical signal patterns. The second is a waveform model, which uses a CNN, which is a convolutional neural network, and that learns the morphology of the electrogram itself, the waveform itself. Those are then combined, and each electrogram assigned a probability that the signal pattern reflects an atrial fibrillation driver region. Now, the output of this model is really patient-specific. It provides a patient-specific map that identifies spatial clusters of dispersion. The blue means that there's no dispersion. The orange is a high likelihood of dispersion, and the red is a very high likelihood of dispersion. Again, remember that the clinical goal is to guide targeted ablation of atrial fibrillation regions. Here's an example of what some of the software might look like or does look like integrating this AI model. So let's break down some of the AI elements themselves. Let's start with the first model that is being used, and that's XGBoost. This is a feature-based learning. And what does the model receive, or what does it get as input? Well, each electrogram is converted into a quantitative signal feature, or several quantitative signal features. It uses physician-labeled features as the base truth or as the ground truth. And some of the features that it might use are frequency, signal amplitude, and the number of deflections. Now, what does XGBoost itself do? It builds many small decision trees that sequentially improve predictions. So kind of conceptually, think of it like this. You have the first tree that learns the simple signal patterns. The second tree corrects errors from the first tree, and then it repeats itself over and over again to really produce a final prediction, which is the sum of many different trees. So what this might look like, for example, is that the model may learn that low voltage plus short cycle length plus asynchronous activation is predictive or suggests dispersion. Now, this model is specifically used because it's very good at identifying nonlinear relationships. It's very good at feature interactions, and it also is very good for small and medium data sets. The second component of this specific model is a convolutional neural network. This is a CNN. And again, what does this model receive? Instead of receiving engineered features like XGBoost, the CNN receives the raw electrogram waveform. So the CNN directly learns from the shape of the signal over time rather than a predefined features. And over time is a key feature here to consider. So some of the examples of waveform characteristics that I might pick up on is peaks and trough in the electrical activation, the waveform fractionation, and the repeated activation patterns. What does a CNN do? Well, this is a deep learning model, and a CNN detects local patterns and applies small filters that scan across the signal and detect features. Think of it like a magnifying glass across a picture. Each layer builds complex representations of the electrogram. So conceptually, think of it as that the CNN analyzes the specific raw waveform. A convolutional filter detects the local patterns, and then each layer learns simple shapes like the peaks, the slopes, and the deflections, whereas the deeper layers learns the complex signal motifs, the fractionation patterns, and the repeated activations. And that results in a final layer output probability of dispersion. What you can kind of think of this as analogous to is, for instance, let's say you have a picture of that image on the right. We all know what it is, but a CNN will look at that image. They will go through the specific pattern that I described before and give you an output layer. For this specific example, it will say, is this a cat? Yes or no. And that's kind of a conceptual analogy to what the CNN actually does. And what it excels at doing specifically is detecting the waveform morphology, capturing temporal relationships, and identifying patterns not captured by engineered features. So it's not necessarily found by the physician itself. So again, let's break down this model into simple terms. The very first input is the intracardiac electrogram. The second is the signal processing, and that's when it splits off into two parallel models. XGBoost is the first one, and a CNN is the second. They come together to give an ensemble prediction, and this is basically what the dispersion probability comes from, the combination of these two models. And from that, you get a spatial mapping and driver region identification onto a 3D map that is individualized for that specific patient. So how is the algorithm verified? How do we know that this AI system is doing what we wanted it to do? Well, the first important thing is, what are we asking it to do? Again, we want the AI system to recognize electrogram dispersions the same way that expert physiologists do, electrophysiologists do. So how did they do that? In this original trial, the investigators performed a double-blind comparison of 18 patients. The regions largely overlapped, and the authors concluded that the system was effectively standardizing expert electrogram interpretation. And one of the key important points of this paper, as well as the tailored AF trial, which we will talk about in 1 second, is that they use clinical endpoints rather than AI metrics. They use validation instead of verification. And as you can see here below, for the original model development, they only tested it in 80 patients. And you can see here that around 86% of patients had freedom from documented atrial fibrillation after one procedure. This is, again, not all of these patients did receive PVI, which is pulmonary vein isolation. This is very important and key, but it's not really testing against standard of care. And that's really what the next trial is going to be doing, and that's the tailored AF trial. This was published in 2025. It's a prospective randomized controlled trial that involves 374 patients randomized across 26 different centers in the US and in Europe. These are adults with atrial fibrillations who are undergoing first-time catheter ablation. The intervention was the AI-guided ablation and pulmonary vein isolation. So unlike the previous report that I just showed you in 2022, this is AI-guided ablation plus PVI compared to PVI alone. The primary endpoint, or the outcome, was freedom from atrial fibrillation at 12 months after a single ablation procedure. Now, over here on the right, you can see the breakdown of the population, and I do want to point out just two specific points. One, you'll see something called an MITT, which is modified intention to treat. And I want to distinguish that from the per protocol patients, because as you can see, there was a few patients that did end up dropping out from the modified intention to treat to the per protocol population, right around 50, 60 patients. And some of these patients did die in the interventional arm, but these deaths were actually attributed not to the procedure themselves, but to other comorbidities such as Guillain-Barré syndrome and metastatic sarcoma. Next, let's talk a little bit about the patient characteristics in this specific trial. The mean age was 66 years old. It was a majority male population at 79% and a female at 21%. The atrial fibrillation characteristics themselves was persistent atrial fibrillation at 82% and long-standing persistent atrial fibrillation at 18%. The mean atrial fibrillation history was 2.6 years. And some of these patients also had cardiac implantable devices within prior to receiving the ablation themselves. So now let's talk about the most important stuff, and that's the outcomes. So what is the primary outcome of this specific trial? Well, freedom from atrial fibrillation at 12 months after a single ablation. In the intention to treat population, it was 88% for AI-guided ablation versus 70% for PVI alone. This is a hazard ratio of 0.34 that was statistically significant. Some of the secondary endpoints were a little bit less impressive. The freedom from any atrial arrhythmia, so that includes atrial tachycardia in addition to atrial fibrillation, was similar after one procedure. And after more than one procedure, one or two procedure, it trended towards significance, but it was not significant. And I think that's an important point of this paper, and probably one of the main things to consider is that the paper describes this as a simplification of atrial fibrillation into an atrial tachycardia, which is a known phenomenon even for PVI. The next endpoint was acute atrial fibrillation termination, and this is just intra-procedural. So, 66% in the AI-guided arm, 15% in the PVI alone arm, which was statistically significant. So now that's the efficacy. Let's talk about the safety. In regards to some of the major complications, they were pretty much the same. It was 4% in the AI-guided versus 3% in the PVI alone. Another safety concern or another consideration is really how long did this procedure take? Now, we do see that the AI-guided ablation required a longer procedural time at 178 minutes versus 92 minutes. You may assume that over time this may become much more efficient, but this does mean that the patients are in the cath lab for longer and are receiving a longer time of ablation. Here is another example of a Kaplan-Meier curve that they used here. This one is freedom from any atrial arrhythmia after one procedure. And this is for the per protocol population, so really the most restricted population. And you can see it does look like it is more significant, but the p-value does not reach statistical significance. Additionally, you can see here on the procedural characteristics on the right that, the location of the specific dispersion pattern that was ablated, as well as the ablation extent in the left atrium, which was 31% compared to around 17%. Acute atrial fibrillation termination by the ablation, you can see here, was 122 out of 186. I described that in the previous slide, but it's much higher than the PVI therapy. And so really that leads to where we are right now, and where is this AI model and how is it being integrated into the current medical care system? And as of right now in the United States and the FDA, this does have FDA 510 clearance as a software as a medical device. It also has clearance in Europe under the CE mark under the EU medical device regulation, meaning that it is commercially marketable and is used clinically in the EU. Just because you have an AI-guided model, that does not mean that it integrates necessarily into your system. And that's where they developed a second version of the specific model. It really involves the same methodology, but it does incorporate a larger database to train on, and also it can be integrated into other software devices that are more commonly used. And that's what's called AF-Xplorer 2. It also has the same clearances, and it's really the same type of model. It's just being able to be integrated more easily. So with that, I do want to end this specific discussion. I want to open it up to the panel to see what are the thoughts of this specific model. Is this something that you would consider to use? And are we, or do we trust this specific model? I will give my 2 cents on this. And, from the actual model itself, you can see here that it is statistically significant with really not too much increased risk. And I think that this really is what AI is supposed to be used for. It's really individualizing care to that specific patient. And I think it's very interesting how they actually did this model and the verification and the validation that they used, because they really used clinical endpoints rather than statistical values to describe the specific models. And the models are largely black box in regards to the CNN. The same with the XGBoost. There is some level of grounding the models with some of the feature labels that was used for the model training. But I think what's the most important thing is how do the patients really respond to the interventions that were given? And you can clearly see here that they are doing better than the anatomical ablation. This was a real-time AI intervention that seems to be doing quite well, and I do expect this to be adopted quite broadly. And I think that is something that is very important for us to become more familiar with moving forward, these specific type of models, and really analyzing not just the clinical outcomes, but maybe some of the limitations and how they actually are used in the real world.